Okay, good morning, everybody. It's my pleasure to introduce Dr. Mohamed Zaazoue. He's a new faculty member. Of course, we all worked with him for a little while, but he's going to talk to us a little bit about his pathway to neurosurgery, and especially neurosurgery in the United States, and also about spine deformity and things that he's learned about spine deformity. Mohamed has had a very long path to becoming a neurosurgeon, dual trained in Egypt and then in Indiana, and then also got his MBA in Indiana, and then a fellowship with orthopedic surgeons. So he's totally confused about how to do things now. And so we're looking forward to this. We're very happy that you've come on to our faculty. Of course, we have many new faculty now, so it's been great to see new faces and learn new things from you guys. So thank you very much.
Thank you. All right, so I'll start the talk today. The first third of it will be an introduction about me and to get to know everyone. First disclosures, it's not relevant to anything I'm going to say today. And the story started in Abu Dhabi, so in the UAE. Beautiful country, very futuristic, like skyscrapers in the middle of the desert, which doesn't make sense, but like really great city, great country, lots of wealth, lots of advanced technology in there, believe it or not. But when you're there, when you're born and raised up there, you're not from there. So I always considered myself to be Egyptian because this is where my parents were from. Again, very rich history, culture. I used to go there every summer. And I decided when I was going to med school, instead of going to med school in the UAE, to go in Egypt. And then the Arab Spring happened towards the end of my medical school. So I decided I want to do more, community service work. And I worked in a few nonprofits first. And then I started a project that really grew bigger than those nonprofits. So they asked me to leave the nonprofit and actually start my own so that it can house that project. So I started Healthy Egyptians with, you needed 10 founders. So I had like 7 founders from that project who moved with me. So I got my wife, well, then she was my fiance, my mother and my brother to be in the founders so that we can start a nonprofit. The whole idea was to spread health education to children in very innovative ways. So we're not really spreading it in an educational way that here are the physicians who are trying to teach you how to be healthy. It's more like, here is a cartoon, here is a comic book, here is a coloring book, puppet shows. And for those kids who can't watch cartoons because they don't have TVs, we created a portable cinema, which we moved on a truck all over the country, and the kids would be able to watch the cartoons in there. So things started to really boom. Forbes heard about this. They did like a search about the stuff we were doing, and they chose me in their 30 under 30 list for 2014. Obviously, when one news agency starts to write about something, Financial Times sent me a reporter to Cairo, and they wrote an article about the work we were doing. And then grants just kept on coming, grant after grant, and we were very fortunate and very, very lucky. So when this happens, then corporates want to take a piece of it. So different corporates wanted us to be, their ambassadors or their face of their campaigns. And all this money went to the nonprofit. So it was very sustainable. I gave talks in big platforms in the Middle East, and this picture in the bottom was Harvard School of Public Health invited me to give a talk to their master's student about how are we incorporating social entrepreneurship in public health, and why is this succeeding, while if we just educate the kids, it would not succeed. So this guy then heard about this, and it's a long history, which we don't have time to go into, but there was a elected president, and then the military took him down, and then the military guy said, I will not run for presidency, then took out the uniform and ran for presidency, and that's him. So obviously I did not want to be involved in this, but he wanted to establish an advisory council, and he said, I want them to be young, I like your ideas, and I want you to be on that council as an advisor to me. I initially did not want to be involved, but then I talked to a politician that I really trusted, and he asked me 3 questions. He said, are you going to get paid from this? Are you going to be advisory or executionary? And are you going to get any extra benefits in your day-to-day work from this? And the answers to all these 3 were no. So he said, you're kind of cornered. You have to accept this. The other thing that The other thing that made me also accept this is his chief of staff, who became the chief of intelligence in the country. Very, very critical position in the Middle East, not just in the country. When I was telling him I'm a busy neurosurgery resident, I don't have time to do this, he looked at me and said, "You don't want to serve your country?" So, so that's a very tricky sentence in Egypt. So you can't really say no to that. So, anyways, I got married to the most intellectual woman I know. She was the editor-in-chief in her university's newspaper, and then her first job, believe it or not, was really a high job in the biggest English-speaking newspaper, and then like within a year, she became the editor-in-chief of that newspaper, Egypt Independent. I was doing my neurosurgery residency. We had our first child, our daughter Tamara, and I had absolutely no plans of leaving Egypt, like zero plans, and my life was great. These are my co-residents. The sad thing about this is, from right to left, neurosurgeon in Germany. The second one is still in Egypt, doing really well. I'm here. Neurosurgeon in the UK. Cardiologist, believe it or not, in DC. So, so really, 1 out of the 5 of my class stayed. Excellent training. We had don't quote me on this, but we had 0 work hour rules because there's no rules in Egypt. So you basically live in that place. There's an apartment in the hospital for the neurosurgery residents, and different rooms, different bedrooms in there, and we basically lived in there. This is my first solo case. I'm not really sure. I'm giving a spine talk today, and I have this picture in here, but for some reason, this is a very special case to me because solo as in skin to skin. I was in my 3rd year of residency, herniating 1-year-old kid. And by the time, Cairo is like a 20 million population city. By the time the attending would be here, the child would be dead. So I just took him to the OR. And by the time I was putting the last few stitches, the attending was there. Kid did great. So we got really good training in there. By the way, 0 drills, 0 perforators, 0 anything. So it's really like Hudson braces, Giggly sews, screws with X-rays, not with nav. There was no nav, but there was no freehand either. So obviously, good things have to come to an end. So these started to happen in Egypt. My wife, being the editor-in-chief, her name was not really on any of the news articles, but she was running the show in the newspaper, and there was a lot of pressure on her to not be an honest journalist, which she is. So the pressure on her, like they can't really take her into interrogation or something for something she didn't even have her name on. But the pressure was in the form of having journalists who worked with her to be, arrested or have their laptops taken or have their houses searched and so on. So lots of pressure that eventually led her to decide, okay, and I decided this with her, that this is not safe now. I don't think you should continue in journalism. So she left her job. She took a job in the UK embassy, really a job for which she was way, way overqualified. But she said, I'll just lay low for some time until things get safer and better in journalism. But the harassment did not stop. If anything, it increased because now she was not really kind of protected by, an umbrella of being the editor-in-chief of a newspaper. And there was a bigger conspiracy now that they can draw around her, which was all not true, that, oh, she's conspiring against Egypt with the UK, which, if you know authoritarian regimes, this is something that can get you life in prison or death penalty. So a decision had to be made. We said, this is not safe. She cannot continue here. She left overnight. We booked 2 tickets, one to the UK, one to the US. We did not know where she would end up. We decided the UK last minute. She went there with my then 1.5-year-old daughter. And as crazy enough of a story this is, I thought, well, I knew that there is no future now for me in the country because my wife and my kid are not there. But it would be even crazier if I try to explain all of this and try to explain to someone why I quit my neurosurgery residency 2 months before graduating. So I decided, okay, I'll take the risk. There's nothing against me in the country. If anything, I'm the advisor to the president. So I'll just have my bags packed in the home in case I need to leave overnight. And I'll just finish my residency. I finished those 2 months, and then I met her in Abu Dhabi. In Egypt, the way it works for faculty is when you finish residency, if you are in a certain ranking in your class when you graduate medical school, you get an automatic position as a faculty in the university. So basically, I just had to sign a paper to have it's like a 10-year position. So it's a lifelong like guarantee that you have this job in Egypt forever. And I did not sign that paper. And my chair at the time, who really treated me as his son, he told me, my son, just sign it. And if you decide you don't want to come back, don't come back. Like, but just sign the paper. And my response to him is, I do not know where I will end up, but I know where I don't want to be. And my rationale is someone else can get that job and have it guaranteed for life if they really want to stay in there. And I made my decision. Like I'm not coming back because of how unsafe it was for my wife. So I did not have a job yet. And then eventually I got a job at Boston Children's Hospital as a research fellow. This is just an example of how my social and cultural life was in Egypt at the time. The guy on the far left and one of the ladies, the one on the far right in there, this is the ambassador of Singapore and his wife. And he really loved us, me and my wife, and he really liked the work I was doing and the work that my wife was doing. So he invited the ambassador of Japan, the regional director of the World Health Organization, and the ambassador of Malaysia into his house, just a dinner in my honor. Really, that was the reason. And like when I remember when Vladimir Putin visited Egypt, Sisi asked me to go with them to the Opera House to watch a ballet show as part of the cultural events that happen in those visits. Very, very interesting guy. Can't talk much about that, but this was my life, and then suddenly a big change in my social life and everything. Like you might think that when you move from Egypt to the US, then like I'm moving for a better life, but I actually had a great life, minus the safety issue for my wife. So at some point even in the OR as neurosurgeons, we make decisions in a split second, and then we own it. We own the responsibility for the decision, the consequences of this. And the reason why I made this decision is for that. Like, this is our picture in Boston. Like, we finally reunited again, and I was very stressed as a research fellow, but I was happy. Like, my wife is safe, my kid is safe. There is no that risk of prison or anything. And I worked really hard at the time. I had 0 USMLEs, 0 papers, nothing. And all of my papers and my work was public health before that. So I worked really hard, finished work really late every day, then went home and studied until like midnight or 1 a.m. or so, and repeated again. And I was just telling Fan, in a year and a half from the moment my plane landed in the US, I got this email, and this was like the best email I ever got. And I don't think it has to do anything about me, because it's really about mentorship you get through the journey. Like, I had 0 idea what the track here is like. And this was my mentor, Dr. Liliana Gumnerova. She was a pediatric neurosurgeon at Boston Children's. She was the tumor person to go to if you need to take out a tumor, one of the best surgeons I've ever seen. And she really mentored me throughout the whole journey. And until today, we are still very close friends. We text almost every other week or so. So Residency 2.0 in Indiana. Indiana had a lot of turmoil before Goodman Campbell split from Indiana. It was like a huge program with like 35 neurosurgeons. And then even after that, it was like 15 neurosurgeons. And that was like after the split, and now they built up again. So lots of volume, lots of surgical experience, lots of autonomy, great people to work with. This is what we looked like when we were not in scrubs. And new city, new state. My daughter went to a school in there. That school actually was an immersion school, so we have to choose a language. We chose Mandarin. So my daughter looks like me, but she's like fluent in Mandarin now. And then a new addition came to our family, my son Adam, and things were very good. Again, mentorship matters. So I knew I was committed to a PGY 8-year after I finished in Indiana, and I was applying to them. It goes through a match. So Dr. Cohen, it's another story, but we can go through it later. But basically, I ended up doing his fellowship because I knew I'm doing a spine fellowship anyways after I'm done. And I learned a lot from him. He's another great surgeon, master surgeon. He does things exactly like his atlas. If anything, if you do something like slightly different from how his videos are, he takes over. If you don't, he doesn't scrub in and he just watches on the screen. Great surgeon, learned a lot from him. This is Dr. Ting, the chair of ENT. They did all the ENT cases together. Like, cases would like be an hour and a half or so, regardless how big it is, not craniopharyngiomas, but most pituitaries. So then I only applied to orthopedic fellowships, and I wanted to see the other aspect of dealing with spine. And this is a picture with me with my co-fellows, really hardworking people. I enjoyed working with them. The three of them were ortho, and I was the only neurosurgeon. So that was, a good mix, me giving decision-making, them being much harder workers than us. Because the other thing is they don't do as much spine cases as we do. So they were really hungry to get cases. And I remember every single weekend I was on call. The guy on the far right, Steven Zhang, we're still very close. We text every day, literally. He would show up to the OR. Like, he's not on call, but he just wants to see as many cases as possible because he knows that after this year, I'm the man and I have to take care of those patients. This is obviously Dr. Vaccaro in the middle. He wrote many things, including the TLEX score, and he was there for our graduation. And it's a theme. Mentorship matters, and I would not be here today if it wasn't for the different mentors I had in my life. And I would say one of the biggest influences in my spine career was this guy, Dr. Manish Gupta. In my opinion, and it's a biased opinion because I'm his mentee, but in my opinion, he's one of the best spine surgeons alive now. And my rationale for this is he taught me to think about the spine in 360 degrees. In some fellowships, you only do posterior only, lateral only, or so on, but he's like a different beast, and we'll talk more about what he does. So I went on job searches. I interviewed at different academic places. I did do one non-academic interview, and I intentionally had it as the first interview just for training purposes. I wasn't very serious, and you would be surprised the amount of money they would throw at you. But also, believe it or not, this was a picture in an interview. This was in Dr. Resnick's house. Fan took that picture, and we had different faculty there with their families, with their kids, and it just had a very different feel than the other job interviews I was on. So we decided we will join UW. And finally, after all this journey, there was some stability. This is us in Devil's Lake a few days before I started work here. So now shifting gears, deformity. Why deformity? Well, to me, the way you choose a subspecialty is just choose something that you enjoy. Choose something that, when I'm scrubbed in, and I had a few long cases, one of them with you, sir, and I didn't feel it's long. I can't even remember if there was music in the OR or not. I was just focused in there, you were focused in there. And this is what people call a state of flow. You just get into your zone and you're comfortable doing that. And to me, that was deformity. I also wanted my subspecialty to be something where you need extra training in, and just like any other field, you would have a big impact on your patients. So why WashU? Many reasons. These are really doesn't even do them justice, these small bullet points. But Dr. Bridwell, if you don't know him, one, he's Dr. Lenke's mentor, and he's the one who started the fellowship there. Two is many grading scales and different things that we do in spine now is because of his work. Dr. Gupta, can't say enough about him. Many other great surgeons in there. The other thing that really got me sold is during the interviews they told me we do an average of 2 PSOs a week, and I said I'm signed up. That's it. I would, if I was lucky, I would see maybe 1 PSO a month or every 2 months in Indiana, and we were busy, but not deformity busy. But they were very deformity focused, and they got patients from all over the country. It wasn't just Missouri patients. And everything was freehand, which is something that I never experienced before. Even in Egypt, we would wear lead and get x-rays while putting the screws, but this really freehand. And you guys and girls have seen me do that. And I learned this from them. I did not do a single freehand screws before that fellowship. Also, a big sell for me was pediatric component was big in there. They have 2 big pediatric hospitals there, St. Louis Children's and Shriners Hospitals. And most of these surgeons would actually operate on adults and peds. And you have attending privileges. So we had our own clinics and we had our own patients that we operated on with 0 attending present. They are always available if you need them, but you have attending privileges and you do your own cases. but there is no free lunch in deformity surgery. And I was just discussing this with Benny that this paper we mentioned, so this is a paper by the biggest names in deformity in the world, not just in the US. So some are Canadian and some are from outside. And they looked at 3-column osteotomies, PSOs, VCRs, and they had prospective patients and retrospective patients by the same surgeons in the same institutions. And they found that when you retrospectively report your data, you have half the number of complications that you actually report if you report it prospectively. And they are being honest. They weren't even lying about it or anything, but it's just, there's no free lunch with deformity. So 1 in 5 or 1 in 6 patients would come out of surgery under the best of the hands in the world with a deficit. And this is risky business. But at the same time, there's optimism in this. So this is a paper published in JAMA this year by Dr. Bridwell. He's the senior author. He actually has his R1 number in his signature. He's so proud of this R1. It is very difficult as a spine surgeon to get an R1, an NIH grant R1 in clinical surgery. So basically, he was doing the surgeries he would do day to day, and he got an R1 for that. And they looked at adult scoliosis. They had a few patients who had surgery, a few who did not have surgery, but by a few, I mean 100 plus. And then they looked at their outcomes 2 years, 5 years, and 8 years. This was the 8-year follow-up. And they found that the patients who did surgery actually did well, even with the complications we just mentioned and other serious complications as well. But overall, those patients were doing well. The thing to note here is the median age was 60 to 61 in both groups. So if you detect this early, if you operate on them early, they usually do much better than the patients who wait until they are in their 70s and 80s and say, I'm miserable, I need something done. I have a big checklist in my head when I'm thinking of those patients to do surgeries, and we won't go through all of this, and you really can't go through all of this in several hours even. But I'll talk about measurements. And I really like this quote: if you can't measure it, you can't improve it. And when I was getting, when I came here and I was getting certain x-rays, I would get not pushback, but like questioning, like, why are you getting a scoli x-ray on a lumbar patient? Or this patient already has this x-ray, why are you getting that x-ray? And when I try to explain some things, then then a light bulb lights up, and then another question. So I tell them, well, I can't see the femoral heads. Then they say, why do you want to see the femoral heads? And it's like, well, I can't measure the PI. Why do you want to measure the PI? So I felt that this is a good talk to start with. How am I thinking, and why am I thinking this way to reach a decision for surgery? And it starts with it doesn't start with him, but I really like the basic concept that he came up with, Dr. Dubousset. Unfortunately, he died this year. An amazing French spine surgeon who came up with a cone of economy, that there is a certain cone around us. When you're standing in that cone, you're having minimal muscle contraction to be in your upright posture. And once you deviate out of this, you start getting lots of muscle contractions to keep yourself in that comfortable zone. And this is where pain and symptoms happen. So clinically, in the coronal plane, you look at the patient's head or you look at their shoulders and you try to determine this. When you look in the sagittal plane, you also try to determine based on how their head is lined up with this. And this is what we write in our notes: leaning forward, leaning to the right, leaning to the left. We have the Adams bend forward test. It is more obvious in growing, chest walls and spines, so more in kids, and I'll show some clinical pictures actually here. So Dr. Gupta in his clinic, which I don't have yet, he has a very well-oiled machine, an army of people who help him so that he gives the best care to his patients. So he has a camera in the OR that someone, really runs, a camera in clinic that someone runs, and everyone gets clinical pictures. So if he wants to present anything, there is always pictures to document how they look like and so on. When I look at this X-ray, well, the first thing I notice is shoulders look symmetrical, but I see a skin fold on one flank and I don't see it on the other. And this gives me, a red flag after doing that fellowship with them. This is zooming in on that skin fold in there. And then when they bend forward, it's just like that cartoon we saw in there. This guy, again, when I look at him, I feel he's leaning a little bit forward. And if you measure the SVA on that X-ray, he is leaning forward. And I see like spinous processes in certain levels, but not in other levels. Why are these prominent in there? And this gives you ideas when you get those clinical pictures. The other thing that I won't go in detail through because you guys do a great job in your fundamentals talks every Friday about these, but there are certain regional, pelvic, and global measures that we measure. So Cobb angle, if you're looking at the coronal plane, or if you try to see how much is the apex of that scoliosis is translated from reference line, or globally is if you use the two reference lines from C7 down and from the sacrum up, how much is the scoliosis translated from this? And these would be global measures. In the sagittal plane, again, a Cobb angle will tell you lordosis or kyphosis. And then the very important ones are the spinopelvic ones, which is the main reason why we want to see the femoral heads in most of these x-rays. Pelvic incidence, obviously, as you know, does not change. And there's a wide range of this, but it is fixed for that patient. There's the pelvic tilt, which I'll give you a trick that I found early in my residency training, is that looking at an AP X-ray, you can tell if the pelvic tilt is okay or not if you look at how open that pelvic inlet is. If it's closed, it's really high, so that's not good. When it's open, that's good. And that's the same patient once you give them a good alignment. And sacral slope. And then there's the SVA, just like the CVA that we mentioned in the coronal plane. This is the SVA, which was very high for that patient that we talked about. You can see it here, 75 millimeters, and it should be within 5 millimeters. So he's leaning 7 centimeters forward at any given moment. And this is in a static picture and X-ray. Probably when he walks, it's even worse. But then it gets more complicated. So it's not just that. Then what is our reference point? Is it C2? Is it C7? Well, Dr. Lenke in 2019 said it might be the cranium. You might want to line up the head to other reference points. And maybe that reference point is not the sacrum. Maybe that reference point should be the hip, the knee, or the ankle. And this is one of the reasons why I get those EOS x-rays, because I want to see how those patients line up globally. Then gets even more complicated. And I don't know if Darius is here or not, but I saw he attended one of those talks that I sent you guys the link for recently. And they were talking about all these different scoring systems, and PI-LL mismatch was what we used to do. But people stopped using those and started to invent new scores. This one looks at how proportional is the spine, was by the European group and mainly by Turkish spine surgeons. And this one, very, very recently, was by Dr. Mike Kelly, who was at WashU and moved to California, and Dr. Lenke and many, many other surgeons. And this is gaining more momentum, and I think this will play an important role in our alignment measurements in the future, which is the L1 pelvic angle or the T4 pelvic angle, and having those within 0 to 5 degrees from each other. So that was the kyphotic patient that we looked at recently. We did a VCR for him, put a cage in there, and now very well aligned with nice smooth curves. And this was 6 months post-op. So how do I assess the flexibility of the curve? Well, different x-rays, which if you look at my clinic notes, you'll see that I'm asking for many x-rays. And why is he asking for all those different x-rays? So supine scoliosis. What does a supine scoliosis shows us? This is a 66-year-old lady. Obviously, very, very bad coronal malalignment. Also, there is a sagittal malalignment with her leaning forward, but this is her standing. When you look at her supine, you can see that the curve is not as bad. So this tells me that there is some flexibility to that curve just by eliminating gravity and her being weight-bearing. Bender's x-rays gives us more ideas. This is the girl that we looked at with the bend forward test. And in here, this is her standing and this is her supine. Again, she corrects herself when she takes her weight off her spine. But then when we ask her to bend right and left, so these are the Bender's x-rays, these are done standing. And you can see that she completely corrects when she bends to the right. And the reason why I quickly say right and left is the way I learned from Dr. Gupta. He said, when you operate on the spine, well, eventually after you do your anterior or lateral, you're operating posterior. So he always has the x-rays with the heart to the left. So that he says, okay, this is bending right, this is bending left. And this is how your brain works easily because you're imagining what you would do in the OR for those patients.
I always said because they're orthopedic surgeons, they can't think 2 steps ahead. Left is on the left.
That might be a point as well. But the other x-ray that I never saw before going to WashU is a push-prone x-ray. So patient is prone on that Scoli x-ray machine, not the EOS machine, just the regular Scoli x-ray. And then those white markers on either side are lead gloves worn by the techs in there. And the techs in there, again, it's a well-oiled machine. We're talking about from the beginning of when the patient gets into the hospital to when they go to rehab. They all know how to deal with deformity. So they push on the apex of the curve on one side, and they have support on here in the upper chest and on the pelvis on the other side. And we're testing, is this flexible or not? And when we see this, I know I don't need a 3-column osteotomy because it's very flexible on bending, it's very flexible on supine, and on push prone, it almost completely corrects. When I get a CT scan, again, so why get a CT scan if you have all those x-rays is because I want to look at bony bridging. If we have that extreme bony bridging on the right side, then I know that no matter what I do from the back, I'm not gonna break this. So those patients will probably need a front back or need a side back or something because he can't break this from the back. Although Dr. Lenke and everyone knows like he's a genius surgeon, he would say he can do anything from the back. And he has x-rays that prove that. So this is a patient that came to us in clinic. Again, clinical x-rays with everyone. There's OR x-rays, which I will show as well. And has this really bad curve, really severe back pain. She's 65, so in a good age. Although I've operated on patients in their 80s with Dr. Gupta, I don't think I'll do this in my first few years. But even their paper shows that patients do much better when they get diagnosed earlier. And you can see that curve in there. You can see the skin folds in her flanks. And this is her standing, this is her supine, not a big change in there. So this is a rigid curve, at least supine and standing. But then benders, almost no changes in there. So very, very rigid curve. You push it with those lead gloves, and those are like, very experienced techs, almost no change in there. So this is a patient that I don't have her CT, but had very big bony bridging from the front. So that kind of surgery. Oh, the other thing I want to go through is, there is the BOW classification, if you've heard of it, which is how coronally aligned these patients are. And if the patient's torso is thrown to the side of the convexity, those are the toughest patients to fix. Because if you just look at that curvature, if I fix that spine straight and I don't fix that fractional curve at the bottom, that patient will be thrown even more to her right side. And that's a BOW C, as you can see here on the far right. So this is a front back surgery with Dr. Gupta, and this was the first surgery for me with him there. And I see on the board it says T10 to L5 ALIF. And this is what I think, okay, that we're gonna put the maximum biggest cage we can put in there in the front. We can use the hammers I used to use or the ortho hammers that I learned from them, and we'll just hammer it in there and put the biggest cages in there. And in reality, it's an exposure I've never seen before. And believe it or not, that vascular surgeon did this in less than an hour. Now, Dr. Gupta is scrubbed in with him, and he's like almost doing it on his own, but he does not do it in the US, but when he travels for missions, he does those exposures on his own. And this is what the spine looks like. The IVC is on downside here, the aorta is on the upper side here. It's like scary looking at these pulsating at you like every second of the case. And this is what it's done. This is the front surgery. It's done now. No cages, no screws, nothing. He just opens up all those bony bridges. He puts some cancellous chips in there, some BMP. He puts a gel foam just to hold things in there, and he closes, and that's it. And then I asked him, like, why did you do all of this from the front with no cages or anything? He said that it can be so malleable from the back when I go on for stage 2. So stage 2, these are the intra-op pictures I told you about. He takes these pictures for every single case. He can present about any surgery he did because he has, the full story in pictures with him. And he takes a picture once all screws are, well, he takes a picture before that, which I did not put in there, with the spine just exposed, and then picture with all the screws in there, picture with the rod in there. And then what I learned from him is if you still see your screws, you haven't put enough bone graft. He's not joking. And this is what the amount of bone graft he'll put at the end of the case. And this is what the patient looks like. Like it's completely corrected in there. And patient, believe it or not, they are happy. So he tells them for the first 3 months after the surgery, you will hate me. But then after that, you will start thinking, maybe this was a good idea. By 1 year, you will say, I wish I did this 10 years earlier. And he was right in almost, I would say, most of the patients. Again, there's no free lunch in deformity. These are tough cases to deal with. The other thing just to pay attention to, which I pay attention to when I'm looking at x-rays, is shoulders. So this was one of the fellow cases. So this patient showed up to the fellow clinic in there, and this was my patient. And her shoulders, you can see, is off. She was in her 30s. She had AIS that did not want to be treated when she was young. And then now back pain is increasing. and she really wanted it treated. So this is post-op, shoulders straight, and you have to pay attention to this intra-op. It is very tough during the surgery to really align the shoulders, because you have the shoulders on the arm boards and you can't really tell what are you doing, as opposed to the cob angles is much easier to align, but it's just something you need to think about. And this is what planning is and measurement is, for at least during my fellowship. And I did this homework with Simon in one of our cases. So I asked him to plan every single screw that we are going to put for the patient, and know the alignment of the different vertebrae in there. And when I took a picture of this lead wall and I sent it to one of my previous mentors, Dr. Eric Potts, which I'm sure Dr. Resnick knows, he told me this is medieval fusion. And why is someone doing this? But, cases go much faster, and you know exactly how every bone looks like. Where's the sclerosis in the bone? Where will it be hard when I'm putting the screw? Will it be soft? Is it going to the right? Is it going to the left? And the other thing that it helps with, Andy, in our case, he knew exactly what screw sizes we need and everything. So everything, is streamlined in the case. Like we go in there, boom, 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 we put our screws, and then we focus on our 3-column osteotomies or our decompression or whatever. And then there's many other things that we will not go through, so we leave a few minutes for questions. But you need to think about bone health. You need to think about, can their heart tolerate such a big surgery or not? Are they in overall health that can tolerate the surgery or not? If their baseline functional status is questionable, a thing I learned from Dr. Gupta is he would ask them to stand up. He would open the door of the clinic and ask them to walk as fast as they can down the hallway and back. And if they couldn't do this, he would tell them, well, our baseline that we're starting from is really low, and maybe I can't help you. And I've learned to be very selective from him. So there's a lot of deformity patients around here, but so far I haven't booked any, because I'm trying to be selective like him, so that most of his cases were home runs, and I hope that I can be half a surgeon that he is. BMI is important. Nicotine. His policy is there is no smoker who should get a deformity surgery. Period. We will do it if you have a deficit, but I will never operate on a smoker. And that's it. And that's his policy. If they want to stop smoking, they stop it for multiple months. He randomly tests them. If they're negative, then he sees them. And he was the only surgeon in WashU who was allowed to screen his patients, which luckily here we are allowed to do that. And finally, I'm in academics because of this, because many people in my journey helped me reach that point. And that's Dr. Quake in our first case together. And before the case, she was telling me, I've never put freehand screws, and this is, her word is, this is intimidating. And I told her, well, it will be fine. And in the surgery, you can see she's not looking at anything else other than the anatomy of the patient. She has a drill in her hand to put the screw in, like an electric screwdriver, because our hands are important. No arthritis when you get older. And she put perfect screws in there. And that's what I have for today. So we have a few minutes for questions. Thank you.
I would say, love for you to give a version of this talk in like a couple, 2-3 years about how your deformity practice has changed.
Yeah.
Because I had the same effect. I went to a fellowship where they've been around a long time. So you kind of see this machine occurring. And I see this happen a lot with trainees from everywhere. Why do I not have an APP holding my hand? Why do I not have cameras in the operating room? All these things. And those were built up over, in Britwell's case, generations.
Oh, yeah.
And so I think that's it's a good place to train, but you can't always replicate right away all the training paradigms. And then I think just kind of getting a feel for, as Gupta mentioned, what patient selection really means.
Yeah.
Not just what the deformities are, but whatever it means. Because I think that was always again, when I started, I came from a deformity program also, and deformed spine was just an operation to be done, because that's kind of how in that time period in 2010, that's how Shaffrey and everybody were talking.
Yeah.
They're like, everybody with a deformity needs an operation because they will not get better otherwise. And so that's what we're doing. And some people did well, some people had very bad complications, you know, so you have these things that we have 10 with that you can see. And I didn't have, you know, probably the best ability to select patients as I do now,
Yeah.
which is like a learned behavior. You also are a little bit nervous when you're young to say no to people. We kind of try to train you at the VA. It's only the beginning. So.
Yeah.
That was an outstanding. You know, when you were finishing the first half, I was thinking, well, it's going to be a letdown now. I wish you would just keep talking about his family at this time. But you know, this was just as good as the first.
Thank you.
Tell us about differences in deformity between adults and
So the reason why, you know, I told you I enjoyed operating on peds in there because they are not just grumpy as the adult patients. They are very resilient. They bounce back. So when I want upright x-rays for an adult, it's usually day 5, day 6, day 7. On peds, it's the next day or the day after maximum. Like they can stand, they can walk with PT. They never really stayed in the hospital more than 3 to 5 days. And that was mainly for the drain. They heal really fast and they do really well. But the other thing, intraoperatively, those adult cases are very daunting. Like it's very tough to break those bridges and like get those alignment well. In most PED cases, not all of them, most PED cases, you can put the spine wherever you want to put it in there. Now, some of them are really, you know, fixed deformities or congenital deformities, and those are tougher. But it's still, in a way, a very rewarding surgery because they do so well after that surgery, and they are usually very thankful. In some of those cases, you can imagine with this rib bump and so on, there is a lot of psychological and there's a lot of research on this that they get affected by this. And maybe is this affecting them, saying that they have back pain or not? Maybe, but they are usually very, very thankful after those types of surgeries. But the biggest difference, I would say, is how flexible the spine is.
what about the difference between neuromuscular and congenital?
Neuromuscular is a different game. So you need to think about, one, are they ambulating or not? And two is, if they're wheelchair bound, how can I let them sit straight? I don't want them to stand straight because they don't stand or walk anyways. But I need to, usually you have to go to the pelvis in those cases. And usually you align your rods slightly different so that they sit straight. It doesn't matter how they stand. So they are slightly different. You usually go slightly bigger on those patients. Yeah. Any other questions?
Yeah, question for you. You know, I always, I think for somebody who does relatively, I'm thinking that this patient is 2 levels of anything. My greatest fear is to fuse somebody who's out of cell and make the problem worse.
Yeah.
And also kind of squander the opportunity to correct the levels that I instrumented.
Yeah.
At that moment. So in your mind, even for the non-deformed surgeons, what is the responsibility of the surgeon who's using a level to correct sagittal imbalance in their planning for, say, like cages? Even if you're only doing 1 or 2 levels, and they can do a full correction, but they don't have the same indication.
Yeah. So I heard a quote from Dr. Shaffer, and I thought he said this quote, but then I heard it in another meeting from another surgeon. But they say in spine surgery, you're either creating deformity or you're treating it. And if I start with a certain lordosis in that level, so let's say you're focusing on 1 or 2 levels for that case, and let's say you're starting with 20 degrees of lordosis or 15 degrees, then at least match that post-op. So that's in the sagittal plane. And then if it's in the coronal plane, I would say if it's a fractional curve, so that lady with the Bowsy, if she has symptoms that go to L4 distribution or L5 distribution, so that it's in that fractional curve, and you're thinking of decompressing this, well, if it's a minimal decompression, like something tubular or endoscopic, yeah, you can do that. But if you're going to decompress more, she'll probably get even more out of alignment. And that would still be okay because she's still as flexible as her baseline is. But if you fuse it in that fractional angle, this is going to make it so much more difficult in the future. So as long as they don't have big coronal or sagittal malalignment, as long as you maintain the pre-op percentages and do the decompression that they came to us for, I would say you would be okay. If you lose any of the lumbar lordosis, or if you keep or increase that coronal malalignment, then this is where it gets much tougher in the future.
I think it'd be like 4 or 5 and 5 and 1 where we get just most common. If you're going to operate at those levels and do their body fusions or feel like the alignment's off already, those are good opportunities to correct that. And it's not just lordotic cages, it's actually removing the posterior elements that help gain lordosis. So many people will get kind of excited about the idea of expandable cages or extremely lordotic anterior cages and things like that, but it's a teeter-totter, and if you take out one side and take out the set joints, you can actually just create that lordosis like a square cage. It doesn't really matter. It'll just compress on the back.
Yeah.
So whether we like it or not, we're all researching.
Yeah.
That's a benzo.
Either pro or
that's a benzo quote, I believe. I think it's.
I'm sure it's much older. Yeah.
It's either in his textbook or biomechanics.
Yeah.
One of those two.
Yeah. Any feedback from the residents in those cases so far we've done?
Joyce, I
Or
know-
preventing deformity, that's the third part of the benzo quote. Yeah. Correcting, causing, or preventing.
Yeah.
And so I appreciate you bringing freehand back around again. When I came from Cleveland, we did freehand also, and trying to maintain that. It's a challenge because we have access in every location to the nav and everything. So I bounce between what we have available and what's reasonably used for patients, and then what we can do. Right?
Yeah.
And so what I have done over the years is try to allow people to do freehand, but also have nav available as adjuncts. Not that you have to do that, but that's many people have seen. So I've gotten less and less instrumentation over the years.
Yeah. And
It's a good skill to have.
Yeah, I told the residents that look at my hair. I came with 0 white hair, so it is very stressful as a young attending, to be teaching on the other side. But I think of the mentors that taught me, and I had 0 freehand experience, and they took that risk and they were teaching me. So hopefully Joyce doesn't see it as intimidating anymore. And what I do slightly different from WashU is they used to get AP and lateral x-rays at the end, and they just look at it. Okay, looks like fine. I do an O-arm spin at the end just so I know that I would sleep better at night.
We used to do like freehand pilot holes and then put
Yeah.
trials in, and then because in fellowship they still didn't have digital imaging, so we would have to get image and then wait 10 minutes, then image and then wait 10 minutes. We do like the first half, get an X-ray, then have them come back, do the second half, then do the EP, and then we put our screws in and they get one more. So it's more of a dance than we normally do.
Do you think freehand is less error prone than navigation?
They're very close. Let's say like the data is like, you get the 95% to the 98%. It's like a 3 to 4% difference kind of thing. And so that, I think that's problematic. This is like enabling technology discussion, right? So that, but you have another example of this where you've done stop it. Shunt revisions forever, and everybody would tell you, why do you need to do that?
Yeah.
And eventually prove that that's a reasonable thing to do, but you've had to do it forever.
Yeah, my reasoning for it is a couple. One is I believe the cases go faster when I don't stop everything to get the arm in, out, and then in, out again. So before and after our instrumentation. But the other thing is less radiation for the patient, and especially in pediatrics, it's a lot of radiation. There's a paper from Harvard, I believe last year, that they said every 1,000 deformity patient, one of them will get cancer iatrogenic from that intraoperative CT. And that's still a big number. I know it's 1 in 1,000, but it's still an iatrogenic cancer. So my reasoning is less radiation. And whenever I talk to any companies and vendors, if they bring the idea of a new nav system or so, I ask them, is it radiation free or not? If it's not, then it's really not better than what we have right now. If they say radiation free, I listen. I try to see, is there something better than what we have right now? But Joyce was telling me she was doing a case after we did the case together. There's different tactile feed to freehand that I taught her that bolted pro. I'm not just putting it there and feeling. I'm really feeling the track all the way in and out. And she told me, well, in a case, I put it in there and I was feeling, and I was definitely out. And there was nerve in that case or something. But there is that tactile feedback. You have to get it to know that serrations in the wall, that bony feeling from down all the way up, medial, lateral, superior, inferior. So there is it is safe if you do it right, and after every step you feel the bone and so on.
I mean, she came back to my room after your case, and now is doing all her shunt springs.
I will not teach her that.
Said it one time that like navigation is the microscope of our generation. There was a big battle over these things. Generation microscope came out, it was like that. So it kind of like goes in cycles, and the hospitals, of course, said the same thing. Why do you need that? You've got food so cheap, so it's expensive. So now you see like it's hard to find a hospital without a microscope. This is kind of that gradual, like slow changes that you see.
I mean, you tighten up the indication.
Yeah, you can do things that
You
you
have
couldn't do
technology, you
before.
don't know what to do with it.
You can also do things you couldn't do before, which is, I think, one of the challenges of adopting new technologies and enabling technologies. Like before, you could do X and you could do it very well, and then as you get something like this, you might be, well, maybe I can do this and be slightly different and be better. I think transfemoidals is a great understanding of that. It's like before, it was basically like 4-0, like how deep you were.
Yeah.
That's pretty sketchy, compared to where you're located, especially if you're trying to do these big operations. Now, with NAV, do all these things, like amazing things, transfemoidally, which you've never done before. So not that I don't want you to do freehand, but I also just get the general philosophy of like, how we're gonna, both maintain tradition.
Yeah. And like Joyce, you went on mission trips and so on. If you need to go to any of those countries to help them in deformity, you have to do freehand. Like there's no way around that, because even X-rays there are like what you mentioned is they print them, they bring them back, and so on. So.
Oh yeah, I mean, like whenever I train surgeons from outside the U.S., except for maybe in Europe, like basically they don't even want to look at that. Like they don't want to look at arm, they don't want to know about that stuff because it's just so disappointing to them that they would have to go, and they want to learn how to do things, what they can do in their country, they have access to. But again, fluoro is an enabling technology. It hasn't been around forever. It's just available now. So I think these things are going to change.
Yeah, for sure.
It'll be cheap to have someday.
Yeah. All right. Thank you, everyone.
Thank you.